The PDL injection was first described in 1904, but became popular in the late 1970s with the introduction of the PeriPress and the Ligmaject. The advantages of this technique is that you can achieve anesthesia in the mandible of one or two teeth without getting anesthesia of the lip or the patient's tongue. Patients truly like that. The onset of profound pulpal anesthesia with the PDL occurs usually within 1 to 2 minutes. It is not necessary in the mandible to give the traditional inferior alveolar nerve block, again, which is a benefit because of the low success rate of that technique in many hands. And finally, one of the major advantages of the PDL is that you can achieve anesthesia on the hot mandibular molar, where other techniques such as the inferior alveolar and the gout gates have failed. Like any technique, there are some negatives to the PDL. For example, the duration of pulpal anesthesia will rarely exceed 1 hour. The technique is also less effective on long-rooted teeth such as maxillary and mandibular canines. And finally, in patients who have large mandibles, physically larger patients, it may be more difficult to achieve pulpal anesthesia with the PDL. Now let's talk about the proper technique for the PDL injection. The first consideration is the needle. In dentistry, we have a variety of needles available, the 25 long and short, the 27 long and short, and the 30 gauge short. For the PDL injection, the preferred needle is either the 30 gauge short or the 27 gauge short. Site selection is an important factor in success of the PDL injection. On mandibular premolars and on incisor teeth, one site, the distolingual line angle, is recommended, while on mandibular molars, two sites, the distolingual line angle and the mesiolingual line angle, are recommended. Site selection in the maxilla is equally important and is similar to that in the mandible. On the premolar and the incisor teeth, one insertion site, the distobuccal line angle, is going to be used, while on the maxillary molars, two injection sites, the distobuccal line angle and the mesiobuccal line angle will be used. Bevel orientation is very important to both the success of the PDL as well as patient comfort. The bevel must be facing towards the tooth, not towards the soft tissue. Initiating a slow flow rate, slowly insert the needle, sliding it down along the root as far as it'll go. When resistance is met, continue a slow flow rate of anesthetic and maintain pressure on the needle throughout the entire injection. Deliver 0.9 milliliters of anesthetic per injection site. On mandibular molars, one full cartridge, 1.8 ml, to be deposited in two injection sites, while on anterior teeth, using one injection site, 0.9 ml or a half a cartridge will be deposited. Make certain that you deliver an adequate volume of anesthetic. At the end of the procedure, in order to prevent the anesthetic from flowing into the patient's mouth, leave the needle in the PDL space for approximately 5 seconds after you remove your foot from the foot pedal. Then remove the needle. Now that the PDL injection has been given properly, look for clinical signs and symptoms of anesthesia. The only clinical sign of anesthesia will be blanching or ischemia of the soft tissue surrounding the tooth. The only clinical symptom of anesthesia will be the patient telling you that the soft tissue or the tooth feels numb.
With the aid of a microscope and intraoral camera, we'll demonstrate the PDL technique clinically. The PDL injection is initiated with the slow flow rate and a very slow needle penetration. Maintain firm pressure on the handpiece to ensure that no leakage of fluid exits from the gingival sulcus. Watch for tissue blanching, which should encompass the tooth circumferentially and extend to the mucogingival junction, mesial and distal to the tooth being anesthetized. Blanching must be evident on the buccal as well as the lingual soft tissues.